All right. Hi, everyone. So I'm Alex. I'm going to be moderating today's presentation. So thanks for registering. Thanks for coming. This is the Women's Health Research Cluster Trainee Presentation Series. So we've done a few of these. They're just a really kind of laid back, good opportunity for trainees to share their research, to practice presentations, and just to have some KT experience here. And we have lots of very interesting presentations from not only trainees across Canada, but we actually even have someone from Germany. So it's becoming almost like a little international event here. So we're so excited to have everyone. So just before we begin, I would just like to acknowledge that we are gathered today on the traditional, ancestral, and unceded territory of the Coast Salish, including the territories of the Musqueam, Tsleil-Waututh, and Squamish nations. And as well, for those of us who aren't joining in Vancouver, if you wouldn't mind just taking a moment to take a breath and acknowledge the history of the land that you are inhabiting today. So we're having a moment of gratitude for that. And we also have some social media. So if you're following along, if you wouldn't mind tagging us, #TraineeBlitz. You can also tag us on Twitter or Facebook and we'll retweet you. So we would love to see everyone tweeting today about any topics that they find interesting or following presenters. Yeah, just connecting with each other. And yeah, so I'll do another reminder probably partway through the presentations just to do some tweeting, but we'll be tweeting throughout. So if you feel free to retweet us as well. All right. So we'll do, each presentation will be about 5 minutes long, and then we'll have about 5 minutes for questions after each presentation. So today we don't have the chat enabled, but what we would like to do is if you have a question for our presenters, if you could just, if you would just be able to raise your hand, and then we'll unmute you, and then you can go ahead and ask your question here. Does that kind of work for everybody? All right, so we'll get started here. So just give me 1 sec. I'm just going to stop sharing screen. So Elise, if you wouldn't mind sharing your screen there.
Sure.
And I'll just introduce you first here. So I'll also introduce our speakers as well. So this is Elise Wiley. So Elise completed her undergraduate studies at the University of Miami in exercise physiology. Oh, and I just lost my screen. Hold on.
Oh, did you want to?
No, it's okay. It was just my screen. My screen went wide, so I couldn't read your bio. It's all good. She's currently in the final stage of completing her Master's of Science in Rehabilitation Science at McMaster University under the supervision of Dr. Ada Tang. Elise's research interests include examining sex and gender-based difference in the physiological and psychosocial markers of cardiovascular health in individuals with stroke. So thanks so much for presenting with us today, Elise, and I'll let you take it from there.
Awesome. Everything's good. You can hear me, right?
Yeah.
Okay, great. So just quickly before I begin, I just wanted to orientate everyone to the the box on the right side. You can place your little Zoom boxes in there just so that you're always oriented on the screen without having to move around. So today I'll be presenting one of my first study from my master's program titled Examining Gender-Based Differences in Exercise Self-Efficacy in Individuals with Stroke. So just a brief overview of stroke, since I know everyone here is from different areas of research. Stroke is defined as a neurological event, a deficit attributed to an acute focal injury of the central nervous system. Okay, I don't know why it keeps doing that. Over 80 million individuals are living with stroke globally. Okay, I'm not sure why it keeps, okay, we'll just do that. And then the incidence of stroke is expected to double by the year of 2050. Individuals with stroke are often deconditioned and live a sedentary lifestyle, which in turn increases the risk for recurrent stroke and other cardiovascular events. The benefits of exercise following stroke are well documented. In particular, aerobic exercise is effective in increasing walking, balance, and cardiovascular fitness, whereas a combination of both aerobic exercise and strength training is particularly effective in increasing cognitive function. And then finally, strength training results in the greatest improvements in limb function and muscular force. However, unfortunately, individuals with stroke often deal with psychosocial challenges, which in turn affects their ability to participate in exercise. One of the primary barriers to exercise implementation in individuals with stroke is having low exercise self-efficacy. It is well documented that these individuals have reduced self-efficacy compared to age-matched older adults. And qualitative research has shown that individuals with stroke often feel limited in their abilities to perform exercise as a result of the impairments from stroke. And now, how does gender and exercise, how are they related? So just, might be frozen here. So so we know that gender is made up of 4 constructs, and and my research focused primarily on gender roles and gender identities. So quickly defining each, gender roles represents the behavioral norms applied in society, which influence an individual's actions, expectations, and experiences. And then with regards to self-efficacy, older women have substantial household and caregiving roles and therefore have less opportunity to develop the skills necessary to participate in physical activity, and in turn have lower self-efficacy compared to men. And with regards to gender identity, which is referred to how an individual sees themselves and is seen by others, again, individuals identifying as women have lower self-efficacy. This leads to my study objective. So we were interested in determining the associations between gender roles and identities with exercise self-efficacy in individuals with stroke. We hypothesized that individuals possessing both masculine roles and identities would have the highest exercise self-efficacy, whereas individuals possessing feminine gender roles would have the lowest self-efficacy. And just a quick overview of our methods. So we developed a gender index using well-established gender roles. So we included 6 gender variables, which included housework, home repairs, lawn repairs, caregiving, and education. And based on our sample of individuals of 40 to 80 years old, education was deemed as a masculine role. And these questions were pulled from the physical activity scale for individuals with disability. And scores range from 0 to 18, where a highest score was indicative of more feminine scales or traits. So this is just a sample question from the Pacific. So it asks, during the past 7 days, how often have you done any light housework, such as dusting, sweeping floors, or washing? And again, if participants answered 0, it would be more of a masculine role. And then if they answered 3, it'd be more of a feminine role. To assess gender identity, we use the BSRI 12, which is a short version of the BSR 60. Again, individuals are characterized as possessing either feminine, masculine, androgynous, or undifferentiated traits based off of their scoring on this. And then we use the self-efficacy for physical activity to assess exercise self-efficacy, where individuals were asked to rate their confidence in their ability to be active in these following situations, where participants rated themselves from not at all confident to extremely confident. And then for analysis, we performed a Pearson's correlation between gender role scores and self-efficacy. And then for gender identity, we performed a one-way ANOVA between the differences in BEM scores and self-efficacy scores. With regards to our results, 13 individuals were enrolled and completed the study. And just a note, this cross-sectional study was part of a larger RCT, which got cut short because of COVID-19. So we would have liked to have more participants, but we were a little bit limited due to the pandemic. So we had 13 individuals, 9 of which were biologically male and 4 were females. Participants had mild to severe strokes. And gender role scores suggested that our sample took on more neutral roles. And the highest percentage of individuals were characterized as possessing feminine gender identities based on the BEM scores. We didn't find any associations between gender roles and exercise self-efficacy with an R value of 0.1 and a p-value of 0.73. But we did, however, find that individuals identifying as women had the lowest self-efficacy, whereas individuals identifying as men had the highest, which was exactly what we hypothesized. So in conclusion, we didn't find any associations between gender roles and exercise self-efficacy. And why this may be, we've speculated that individuals with stroke might have had lower self-efficacy across a broad range of roles. So the stroke-related impairments may have affected ability to perform gender roles undertaken prior to stroke. So for example, a woman who had a stroke may not be able to undertake her previous roles of caregiving and household responsibilities, therefore resulting in role reversal. So these findings suggest that perhaps a gender index based off of gender roles in individuals and older adults may not be applicable in this specific cohort. And indeed, we did find that individuals with feminine identities had the lowest exercise self-efficacy, whereas individuals identifying as men had the highest. And again, why? So there's been literature to support that individuals with stroke identifying as women often have altered body image as a result of their stroke-related impairments, whereas these observations haven't been noted in men. And then women, even without stroke, have health pressures such as the influence of others to achieve an ideal body image. And this might have been felt even before stroke. So as a consequence of stroke, it could have been heightened even more, resulting in, again, the lower self-efficacy in the women. And so how can we address the lower self-efficacy in these women? So perhaps a greater focus on rehabilitation aimed to optimize self-esteem, as it is directly related to self-efficacy. And again, when individuals have more of a focus on body image, they typically have lower self-esteem. So these two are interrelated. So again, we would want to optimize both of these. Also, older women prefer exercising with others. So again, rehab programs incorporating group-based interventions and receiving feedback from PTs may increase exercise self-efficacy in these women. And then just some final thoughts and future directions. Gender identity can be assessed through the BSR-12, as we have shown. And there remains a need for validated gender indices in this specific population, as again, typical gender roles in older adults may not be applicable in this population. So perhaps qualitative studies aimed at understanding what gender roles are indeed applicable in stroke may be the first steps in understanding these gender-based differences. And again, of course, there remains a great need for sex and gender in all fields of research. And that's it from me. Just my acknowledgements here. I know I'm probably over 5 minutes, so I won't go through all of them. And then questions.
Awesome, thanks so much, Elise, that was great. Yeah, so I think if any participants raise hands, I'm not sure, I can't see if I can unmute anyone. Or no, wait, yes, I can. Just if you have a question, maybe just try raising your hand and then we'll see what happens. Oh, actually, it looks like you can just unmute yourself. So maybe if you have a question, you can just go ahead and unmute yourself. If anyone has any questions.
Oh, go for it.
I was just wondering, because you mentioned that your study kind of had to be cut short.
Yeah.
Right now, are you guys planning on starting back up when things are possible?
Hopefully. Again, it's a high-risk population, so we're not really sure when that may be. I know McMaster was given the heads up today that we can continue with more healthier cohorts with research, so that's promising. It is, again, this was a cross-sectional study of a large funded RCT, so it's meant to be a 5-year study, so hopefully sometime in that 5 years I'll be able to gain a little more data from it, especially when looking at the roles. I do acknowledge that we might have been underpowered to look at those associations with only 13 people, so.
Thanks.
I have a question if I can ask.
Yeah.
Have you thought of adding other gender-related factors to your analysis? Like, I don't know, maybe occupation or, well, education you add, but other of those things that might be associated with gender?
Yeah, for sure. I totally agree. I'm looking through previous literature that there's not many studies that have done gender indices, but for sure there's definitely others that we missed. Again, since it was a large study, we didn't want to bombard the participants with a bunch of questionnaires. So we were actually conveniently already looking at the PACIPID. And then I said, oh, well, some of these questions capture what I'd be looking for in a gender indices. So we kind of just pulled from there. But I do agree there's definitely room for other such as income, occupation, even disability status differs in between men and women. So that would be definitely future directions.
And I was even thinking of things like, for example, smoking status or drinking status, because those affect both or are affected by gender, but also impact your, cardiovascular health that for your stroke patient might be important.
For sure. Yeah, good. That's a great point. Thank you.
I have a question as well. I was just wondering, and maybe this is a question for everybody with including sex and gender, is how you feel COVID might confound the results or confound the gender-related factors that we associate with men and women. So if there's a lot more men who are at home who are all of a sudden doing more housework, or women who maybe are working because their job wasn't impacted, just wondering if you have any thoughts about that.
Yeah, it's a really good point. I think there's still literature to suggest that women are still a little more affected by the disparities with COVID, with caregiving roles, and unable to even do work because of having to look after the kids while at home. But yeah, that is definitely, I think that'd be a whole other study to look at to see if there's changes pre-post COVID.
Yeah, exactly. And then also women just being like compounded even more by the pandemic than men. So
yeah.
Great. Nice work.
Thanks.
Okay, I think we'll probably move on to our next presenter. So Keon, if you wouldn't mind trying sharing your screen. Let's see. Thanks, Elisa, that was great. And just while she's doing that, I'll just introduce her. So Keon is a second-year master's student in the Department of Sociology. She completed her undergraduate training at McMaster University, where she received her Bachelor of Science in Life Sciences and Bachelor of Arts in Health Sciences, summa cum laude. Her research interests exist in the nexus between race, gender, class, and health. Broadly speaking, Keon is interested in the structural determinants of health and the interplay between social and health inequities. She is particularly interested in the use of Black feminist thought to better understand and address contemporary racial health inequities. So excited to see the presentation. So take it away there, Keon.
Thank you, everyone. Thank you, Alex. So today I'll be talking to you about my ongoing master's research that's examining the prenatal healthcare experiences of Black women in Canada and Jamaica. So before beginning, I'd just like to acknowledge that this research is supported in part by funding from the Social Sciences and Humanities Research Council of Canada. And I'd also like to acknowledge my supervisor, Dr. Jerry Veenstra, and my committee members, Dr. Moji Anderson and Dr. Sinika Elliott, for their scholarly support and mentorship. So despite marked improvements in maternal and infant mortality rates, Black women continue to experience worse perinatal outcomes than women of most other racial groups. For example, Black American women are 3 to 4 times more likely to die while giving birth as compared to white American women, and Black infants are 2 times more likely to die than white infants in America. Strong evidence suggests that approximately 60% of these pregnancy-related deaths are preventable, and this suggests that such poor perinatal outcomes aren't natural, but rather reflect pervasive social inequalities based on intersecting social identities, such as race, gender, and class. So scholars conceptualize racism as a chronic psychosocial stressor in the lives of Black people that contributes to a variety of negative health outcomes. And for Black women, stress from racism is further compounded by sexism and other forms of oppression. And we know that stress experienced during pregnancy has been shown to be a more powerful contributor to adverse birth outcomes than general stress. And Black women have been shown to experience unique sources of stress during their pregnancy, particularly in the healthcare setting. So Black Americans are 4 times more likely to experience discrimination in the healthcare setting. And Black pregnant women report having negative relationships with their prenatal providers characterized by judgment, disrespect, stressful interactions, inconsistent support, and unmet information needs. So as Black women typically increase their interactions with the healthcare system during pregnancy, the prenatal healthcare encounter is an appropriate setting to investigate to help promote quality care. So as you may have already noticed, so much of the literature on the prenatal healthcare experiences of Black women has been based in the United States, but Black feminist scholars contend that the intersection of racism and sexism produces common challenges for Black women worldwide, but that these challenges are uniquely articulated based on varying national contexts. So further investigation into the experiences of adult Black women outside of the US is therefore warranted. And this brings me to the purpose of my research, which is to investigate the prenatal healthcare experiences of Black women in Canada and Jamaica. So I'm doing this by answering the research question, what are the similarities and differences in the prenatal healthcare experiences of Black women in Jamaica and Canada, and what accounts for these similarities and differences? So I'm doing a qualitative mixed method study using constructivist grounded theory as described by Sharmaz and the case study methodology as described by Small and Yin. In terms of my recruitment and data collection strategy, I've recruited exclusively through social media due to COVID restrictions, and I've conducted in-depth, semi-structured virtual interviews with both Jamaican and Canadian women. At this point of the research process, I've conducted a total of 15 interviews, 8 with Canadian women and 7 with Jamaican women, and the length of interviews range from about 30 minutes to about an hour and a half, with the average length of an interview being about 1 hour. So I've not yet began data analysis. I'm still collecting my data, but I'll quickly just describe some of the early themes that I've constructed through reviewing my interview memos. And I'll start with what I found among my Canadian participants. And the first theme I'll discuss is what I refer to as colorblind healthcare. So I found that many of my participants felt that their healthcare providers didn't take their race into account when providing care and giving them health information. So women wanted their provider to acknowledge their race and ethnicity, but they just didn't want to be treated poorly because of it. So many women often had to do their own research about conditions that were more prevalent among Black women and then ask their provider about it in order to receive race-relevant health information. So I started to think about this as colorblind healthcare, in that women felt that the care and health information that they received was colorblind and wasn't tailored to them specifically as Black women. Another early theme among my Canadian participants was their desire for holistic care. So many women just didn't want their pregnancy experience to be strictly biomedical and felt that receiving care within the existing healthcare system would be impersonal and standard based off of their personal experiences in the healthcare system. So many women talked about midwives, talked about how much they enjoyed their experiences with midwives, talked about their desire to use a midwife for their next pregnancy. And some women discussed changing from an OB or a family doc to a midwife because of poor treatment. An early theme among my Jamaican participants was the shift from private to public care. So Jamaica has a 2-tier healthcare system, and many women discussed receiving private prenatal care, but delivering in a public hospital. And this shift from private to public was often distressing due to changes in the quality of care they received. And this kind of ties into the second early theme among my Jamaican participants, was that many of them recall poor in-hospital postnatal care, which was of course a stressful experience. So overall, both Jamaican and Canadian women shared an awareness about the mistreatment of Black people, especially Black women in the US healthcare system, but the way that they spoke about this knowledge differed. So Jamaican women often distanced themselves from the healthcare experiences of US Black women. They'd say things like, you know, I know it's like that in the US, but here in Jamaica, it's not really like that. We don't have a race problem, we have more of a class problem. My Canadian participants, on the other hand, they thought about the experiences of US Black women as more close to home. So many of them appear to anticipate poor treatment in the healthcare system during their pregnancy. I also found that both Jamaican and Canadian women had an openness to talk about race, but a hesitance to talk and name racism in the healthcare system. And this is something that was particularly interesting to me as I was doing my interviews, and is something that I'm currently exploring further with my participants through follow-up interviews, just to get a better idea of the role that race plays in their everyday life. So that concludes my presentation. Thank you for listening, and I can take any questions now.
Awesome, that was great, Keon. I have a quick question. I was curious how the social media recruitment's going.
It went really well. I actually recruited all of my Canadian participants in one day, surprisingly.
Wow.
Yeah, through a Black Toronto Facebook group. So my Canadian participants are primarily in the Greater Toronto area.
Right.
It was a bit more tricky with the Jamaican participants because my Jamaican network isn't that large, but it was surprisingly better than I expected.
That's really cool. I think it's such an interesting way to do it in this, as long as you can make it ethically sound and stuff, but I think it's going to be such a powerful way to recruit in the future.
Right.
We'll see.
I see Travis raised his hand. I don't know if...
Oh, Travis, you can just unmute yourself. You should just be able to unmute yourself.
Sorry, I'm in like, well, I can show.
Oh, good. I didn't have that figured out either at the beginning.
I'm like reporting from the lab here. Yes, I did have a quick question too. I was just wondering if there were any, if you asked any of the participants about social support and if that differed from the women being in Canada versus being in Jamaica, if there was differences in social support and what role that might play in their perceptions of healthcare that they're receiving and how it's going.
Right. I didn't ask for it, but it came up a lot among my Canadian participants. My Jamaican participants didn't talk much about social support. They were kind of, yeah, it was mostly when I conducted the interviews specifically about the care that they received, but a lot of my Canadian participants talked about not feeling like they had enough social support and wanting more support for pregnant Black women. Like they found a lot of resources and support for pregnant women in general, but they found like a scarcity of resources and support for pregnant Black women. So that's definitely something that came up a lot in conversations, just naturally, because it wasn't something that I initially prompted for in my interviews.
Awesome, thank you so much.
Thank you.
I had a quick question. Thank you, Kayon, for your presentation. So in the beginning, you had mentioned some statistics, American statistics, but I'm wondering if you had any statistics on maternal health for Black women here in Canada.
Yeah, it's difficult to find that. There's not much race-based data on that in Canada. So I actually haven't come across any literature, which is why I drove primarily on American statistics. Canada has a problem with not wanting to collect race-based health statistics. Or data rather. So it's not something that I was able to find when researching, but hopefully that will change in the near future.
Great. Any other last ones there?
May I ask a question?
Yeah, go for it.
So will you be following up with the women after they give birth?
So most of the women already gave birth. So the eligibility criteria was that they had given birth within the past 2 years. So most women gave birth in the past year. I don't think I spoke to any women who are actually currently pregnant. Like I think one of my participants had their baby in June, and I think that was like the newest mother, but yeah, most of them had already delivered.
Do you have any questions about like specific aspects of postpartum care? Just because I'm curious, because postpartum depression is already so poorly monitored, but it has been reported that it's even worse. I believe for Black women and other minorities that it's just seen as, just complaining or just saying they feel bad and not really being recognized as an actual condition. So I was just curious if you had any questions about that.
Yeah, so postnatal depression and postnatal care wasn't something that I actually was like examining in my research. It's something that just came up actually when I was speaking to women, because I was looking specifically at prenatal care, but I guess it's hard in general to just kind of discern prenatal and postnatal, especially when the whole thing kind of comes together. But yeah, I didn't ask any questions specifically looking at postnatal depression, but the care specifically among Jamaican women that they received postnatally was something that just emerged in conversation with them.
Thanks.
Thank you.
Awesome. Okay, it's so we could take so many questions, but we'll move on to the next person because we'll try and let everyone go by their lunch hours. So thank you so much, Kayon. That was awesome. All right, so Karen Joe is going to be next. So if we'll get you to share your screen there, Ranjo, there we go. Okay, so Ranjo is a first-year Master's in Science student in Psychology program at the University of Northern British Columbia. She completed her undergraduate studies at UNBC this year, earning a Bachelor of Science honors in Psychology. Her research interests include the influences of sex and gender in biopsychology. Under the supervision of Dr. Anna, is it how do you say her last name?
Duchesne.
Duchesne, okay, thank you. Ranjo will be looking into the effects of ovarian hormones, the effects that ovarian hormones may have on the recruitment of learning strategies. So looking forward to this. So I'll let you go for it there.
Sure. So hi everyone. So my presentation, as Alex already said, is into the investigation of how ovarian hormones can affect the differential recruitment of learning strategies. Here we go. All right. So in general, my study is looking at how estrogen and progesterone affect cognition. Within cognition, I'm looking specifically into cognitive flexibility, which is the ability to shift attention and change behaviors based on changes in the environment. And this ability to change behaviors can be seen on a spectrum from more rigid behaviors, which is habitual learning strategies, to more flexible behaviors, which would be labeled as cognitive learning strategies. And it is important to learn more about learning strategies as these have been implicated in PTSD, OCD, and addictions. That being said, recruiting different learning strategies while doing different tasks doesn't mean that the performance differs. It just means that the way the task is being done is different. All right, and so learning strategies permeate lots of different domains of cognition. We're looking at three specific domains of cognition. Firstly, it's navigational learning, which is learning how to maneuver through an environment towards a specific goal or reward. Then we're also looking at decision making, which is deciding to make choices or switching behaviors based on the perceived value of the potential outcomes. And we're also looking at probabilistic classification learning, which is learning which outcome is indicated by the cues that could be presented in certain tasks based on associated probabilities. And within each of these strategies, or within each of these domains, the tasks can be done with more flexible behaviors, or they can be done in more inflexible methods, and those are on the screen there. And so in terms of how estrogen and progesterone affect learning strategy recruitment, it has been seen that estrogen has a great effect on this recruitment. This has been seen in a lot of animal literature. Within humans, we've also seen that progesterone is also very influential. However, the results of these studies aren't very conclusive. Some studies show certain strategies being recruited more during different phases of the menstrual cycle with different levels of estrogen and progesterone. One study that we're going to be replicating for our experiment here is the study by Scheringer and Pletzer. Specifically, like what's relevant for our study, they looked at women within their follicular stage and luteal stage. Within the follicular stage, their estrogen levels are high, and within the luteal stage, their progesterone and estrogen levels are high. And they looked at their navigational learning abilities and the strategies that they used. And they found that within the luteal phase, the women were more successful using a landmark-based strategy, which is more of the rigid habitual learning strategy that we talked about before. And so with our study, we're trying to replicate these findings by Scheringer and Pletzer, but we're within navigational learning, but we're also trying to expand these findings into the domains of probabilistic classification learning and also within decision-making. And to do this, we're going to be tracking the menstrual cycle of each participant that signs up by asking them about whether they've started their menses every other day. Once they say that they have started their menses, we're going to ask them to test 3 times, once during their menses when both of the hormones will be low, once during their late follicular phase when estrogen would be high, and once during the luteal phase when both of the hormones are going to be at high levels. And we're going to be setting up at-home sessions. So we're going to be in contact with them through Zoom. And through these sessions, we're going to be asking them to take biological samples of estrogen and progesterone through saliva sampling. And we're going to be asking them to do 1 to 3 tasks. All these tasks are going to be counterbalanced throughout the duration of the experiment. We're going to be asking them to do the spatial navigation task, weather prediction task to test for probabilistic classification, and patch foraging task for decision making. And for expected results, we're expecting to see a replication and expansion of the results from Schering and Pletzer. So in summary, we're thinking that we're going to get the balance to shift towards more cognitive, flexible learning strategies with higher levels of estrogen, and to see the opposite effect with higher levels of progesterone. And that's it.
Awesome. Thank you so much. That was really interesting. All right. Does anyone have questions?
I have a question. What type of spatial navigation task do you use, or what have they used in the paper that you're trying to replicate?
In the paper, they have there's a grid with different icons within. It's like a 9x9 grid with different icons within each box, and it's accompanied by different instructions based on the strategy that we're looking at. It's more of a 2D kind of task rather than a 3D virtual task, but we're hoping to see like something with that as well.
Yeah, maybe using a cognitive map formation task would be more helpful for sure, because humans usually encode navigation like that.
For sure, yeah. We'll definitely look into that as well and see.
Great work.
Thank you.
I have a quick question. I'm fascinated by your ability to pivot and do this work in a home-based setting where you're using salivary samples. Are you also going to be using like ovulation, pregnancy testing, like any of those type of at-home tests as well?
We are not going to be doing ovulation tests. We found literature where they've seen differences in performance when people are primed about ovulation. Even with the saliva sampling, the purpose of the saliva samples is going to be disclosed to the participants towards the end of the experiment when we're debriefing them. We're trying to keep all the priming about the menstrual cycle and the hormone levels till the end, just to make sure that there's no effect on the performance.
I have a quick question too. What would be the like end result of these? So you talked a little bit about PTSD, anxiety. Do you have an idea where this would be like applied possibly, say like in clinical practice or etc., like down the road?
Yeah, I feel like in general, it's just to clarify the results that we've seen so far. Mm-hmm. In terms of application, I think it would allow for a better informed way of dealing with those disorders if these effects of ovarian hormones are actually in fact true. It would allow professionals to be able to have a more informed practice in terms of like how they treat their patients.
Mm-hmm. Cool. Thanks. All right. Anyone else? Going once, going twice? Okay, sounds good. Thank you so much. That was a great presentation. Very interesting work. And then, so next up, we'll have Rachel share her screen, if you can, Rachel. And so Rachel is a third-year PhD candidate in cognitive neuroscience at the Max Planck Institute for Human Cognitive and Brain Sciences. She completed her undergraduate training at Harvard University, where she studied the influence of ovarian hormones on psychological and neurocorrelates of fear conditioning and extinction in women suffering from anxiety and post-traumatic stress disorder. Her research now focuses on how ovarian hormones and the serotonergic system interact to influence brain microstructure and neurochemistry across the female lifespan, and the implications that these interactions have for depression, susceptibility, resilience, and treatment. So welcome from Germany, Rachel, and looking forward to your presentation.
Well, thanks. Okay, one final check. Can you see the correct screen?
Yep, it looks like you've got it on full presenter mode.
Okay, great, thanks. Okay, then I'll just jump right in for the sake of time. Okay, so, I mean, actually, as we've really seen today, all of us know that diversity drives scientific discovery. And yet, while there are known sex differences in brain structure and function, in neuropsychiatric and neurodegenerative disease risk, as well as in response to pharmaceuticals, there is this persistent underrepresentation of female participants, particularly in neuroscience research and in clinical trials. So this sex bias, alongside these sex-driven differences in neurobiology, may largely explain why women typically experience more adverse events to pharmacological interventions as compared to men. So this is kind of the motivation for my study, and this thought that we need to explicitly investigate sex-specific risk trajectories and treatment options, particularly when we're looking at pathologies that present differently in men and women. So women are twice as likely to suffer from a depressive illness. And while selective serotonin reuptake inhibitors, or SSRIs, are the first-line treatment for the majority of patients with depression and anxiety, the response rates are highly variable, they're sex-dependent, and this can all lead to weeks of trial and error in an attempt to find that right medication. So to understand the drug and responsivity to the drug on a foundational level, we need a well-characterized model in health to first clarify the neurophysiological mechanisms underlying SSRI action in women, and secondly, to identify a biomarker that could potentially be used to guide antidepressant treatment decisions. So in our study, we recruited healthy women who were randomized to either placebo or escitalopram, escitalopram being a very commonly prescribed and fast-acting SSRI. Participants completed 3 resting state EEG measurements. The first measure was a baseline prior to drug intake. There was another measure after a single dose of either escitalopram or placebo, and then a final third measurement after a week of daily administration. So this way we were able to showcase 2 different kinetic states, single dose and steady state, to capture a clinically relevant time window. So all of our participants were healthy and of reproductive age, and also using oral contraceptives in order to downregulate endogenous ovarian hormone fluctuations. Our main measure of interest was cortical excitation inhibition balance, where dysregulation in this balance has been thought to play a role in neuropsychiatric disorders. So we measured excitation inhibition balance using 1/f slope of the power spectra. We can talk more about it later if you'd like, but the main takeaway is that a decrease or flattening of the slope, which is what you see in the figure with the solid line, that decrease in slope reflects an increase in cortical excitation inhibition balance, and vice versa. So in our between group comparisons, we observed a significant decrease in slope or increase in excitation inhibition balance after both a single dose and a week of escitalopram as compared to the placebo group. And within the escitalopram group, we observed significant changes across all 3 time points. So slope decreased from baseline to single dose, it decreased from baseline to steady state, and it increased from single dose to steady state. So the takeaway of these analyses is that what we see is that escitalopram reliably manipulates this stable measure of excitation inhibition balance. And we observed an increase in excitation inhibition balance after a single dose and after 1 week of escitalopram administration. And then finally, as we had set out to identify a potential biomarker for individual responsivity, we tested whether slope at one time point could predict the change in slope at a later time point. And what we saw was that both baseline and single dose slope could predict the steady state response. So finally, we ran a moderation analysis and found that higher levels of plasma escitalopram are associated with a better maintenance of increased excitation inhibition balance during the drug administration week at an individual level. So excitation inhibition balance at steady state levels of escitalopram can be predicted by baseline and single dose neural response. And inter-individual responsivity can influence the strength of this relationship via drug kinetics. So since we observed that both baseline and single dose signal could predict steady state signal, and that taking into account escitalopram plasma levels strengthen this relationship, we're proposing that 1/f slope may serve as a non-invasive biomarker for predicting individual neuroresponsivity to SSRIs. Establishing this model in healthy women provides a conceptual framework to clarify the effects of SSRIs on human cortical excitation inhibition balance. And we hope that our findings can provide a platform for future translational research in clinical populations, such as in depression and treatment-resistant depression, overall to inform pharmacological treatment and monitoring strategies at a single patient level. So with that, I'd like to thank my supervisor and mentor, Dr. Yulia Saha. Thank you to the collaborators on this study. Thank you for your attention, and then I'll just leave the results up here, and I'd be happy to take any questions.
Thanks, Rachel, that was great. All right, if anyone has questions, go for it. I feel like when you're moderating, you always end up being the one that asks questions. I'll start one off. So
Sure.
What are your next steps with this? If you're, is this a project you're going to be continuing on with? Like, where do you see this research going?
So this will be it for this study, but the hope is that the next study, now that we've kind of identified this non-invasive mechanistic biomarker, potential one, and it's, the nice thing about it is it's very easy to get this data. If you have an EEG cap, you can do it. It's, in that sense, it's non-invasive. The hope would be then to transfer these findings to a clinical population. So I'm particularly interested in depression and treatment-resistant depression.
Mm-hmm.
So that's where I'm hoping to take it next.
Great, thank you. Just give it one more minute. I guess you just answered everyone's questions and just explained it so well, that's all. Yeah.
That's fun, yeah.
Last chance. I guess also for everyone, all of our presenters are listed on the Women's Health Research Cluster website with, I think, their Twitter handles as well. So if you think of questions after the fact, you can ask them. And then also just a quick little reminder to be tweeting, and you know, if you hear little sound bites throughout the presentation, just feel free to tag us and we'll retweet you. But yeah, just trying to get all that good knowledge translation happening, right? So I guess we'll move on to our next presenter, last but certainly not least, with Veronica. So I'll get you to share your screen there, Veronica. Okay. So originally from Italy, Veronica obtained a master in neuroscience from the University of L'Aquila. She moved to Canada in 2011 to start a PhD in brain and cognitive sciences at the Department of Psychology at the University of Calgary. In June 2017, she moved to the Laboratory of Human Cerebrovascular Physiology as a postdoctoral fellow. Since then, she has been working on findings from the Brain in Motion BIM study, looking at the effects of 6-month aerobic exercise intervention on sleep, brain health, and cognition. She is currently involved in the data collection and analysis of the new randomized control trial, Brain in Motion 2, Recently, she developed an interest in the investigation of sex and gender differences in sleep and cerebrovascular regulation. Veronica is supported by the Alzheimer's Society of Canada Research Program, postdoctoral fellowship, and by the O'Brien Institute Center of Aging. So welcome, Veronica, and take it away.
Okay, no, can you hear me now? Yes. Okay, so good afternoon, everyone. My name is Veronica, and as you said, I'm a postdoctoral fellow. However, today I'm gonna discuss this research that started a few months ago and was based mainly on what I had studied during my PhD, which is the relationship between sleep and emotional empathy. So the title of my presentation is Sex and Gender Differences in Sleep, Empathy, and Mood During the COVID-19 Pandemic. And okay, so I would like to start with defining empathy. So empathy is the ability to understand someone else's thoughts, emotions, and feelings, and usually can be subdivided in a cognitive and an emotional component. Here I'll focus on this emotional component, which is this ability to understand, but through vicarious sharing. So means that you are actually feeling what somebody else is experiencing. This ability develops very early in life, so even little babies have this ability, and it's called emotional contagion. As you see in this picture here, these two babies are crying at the same time, so sharing the same emotion, but they have whatsoever no idea why they are sharing this emotion. So emotional empathy doesn't imply cognitive understanding of the emotions. And so during my PhD, I looked at how emotional empathy is impacted by sleep. And first of all, I acutely sleep deprived some participants and then measured their emotional empathy and saw that when they were sleep deprived, their emotional empathy responses were blunted. So they were caring less for others. And then we looked at natural occurring changes in sleep quality, so how your sleep changes day by day and how that is associated with empathy, and found a linear association between the two things. In a way, if you have a better quality of sleep, you care more, you're more empathetic. If your quality of sleep is worse, you tend to care less. And also we studied the neural underpinnings of this relationship and found that there is this region in the brain, the right posterior insula, that seems to mediate this relationship. And finally, we studied this relationship in people that do stressful occupations, such as experienced paramedic. So we've seen that in these people that also do shift work, they start to develop sleep disturbances such as insomnia, and their emotional empathy tends to go down. So with this background, when the COVID-19 pandemic hit, I thought that, in this situation, this relationship would hold and also maybe be different as compared to non-pandemic times. So another important thing to consider is sex differences in all of these. We know that there are known sex and gender differences in empathy, with women experiencing more emotional empathy as compared to men. So men are more on the cognitive side. Also, we know that there are sex differences in sleep, and particularly how sleep impacts cognition. And this seems to be mediated by hormones, right? So the role of sex hormones impacts this relationship. And then recently, data are started to come up about sex differences in how males and females react differently to the pandemic, but we have to separate what is biological sex from gender, because we know that biological sex can affect more infection and mortality rates, and more data are coming up with the fact that men seems to suffer more for the health consequences of the COVID-19 virus. And this might be due to differences in immune responses, different number of ACE2 receptors that are the receptors where COVID attaches, and also protective role of estrogens. So this is from a sex point of view, but from a gender point of view, what's important is that gender influence where people go. So pattern of exposures are more affected by gender and vice versa. So here I wanted to investigate how sex and gender impacted sleep, mood, and empathy during the isolation period. And then I wanted to see how these things changed through the isolation. So if there was a difference between what was in March to what was in June. And then we also wanted to look at the association between sleep and mood and empathy separately in the two sexes. So we created an online survey. We used SurveyMonkey, and we also recruited participants through social media, word of mouth, and the University of Calgary research system. We recruited, at the time when I pulled the data, 638 volunteers, and the complete data sets included 573, mainly Canadian, so these analyses are focused on Canadian people. As you can see, there is a disproportion between females and males, with higher number of females. This can be a selection bias due to the fact that females tend to respond more to online surveys, particularly when they're asked about mood and emotions. So for this, we had to use non-parametric statistics to look at differences. Also, mean age is around 25, and all of them are fairly high educated. On the left-hand side here, you can see the distribution for sex, gender identity, sexual identity, and ethnicity. So I have ethnicity data as well that I can show you if you're interested, but we didn't do actually statistical analysis on that because many of the ethnicities are unfortunately not well represented in the sample. And this first table shows you the analysis on sex differences. So we can see that females had a statistically significantly lower quality of sleep in general. They had lower sleep efficiency, and but they had higher symptom of insomnia, anxiety, depression, trauma, but also they had higher empathy. So they were more empathetic towards others as compared to males. In terms of sexual identity, we found that participants that identified themselves as straight had the lowest quality of sleep as compared to others, while homosexual participants had instead the highest symptoms of insomnia as compared to others. And bisexual and pansexual participants, however, were the ones that had the highest empathy scores. In terms of how these things changed through the pandemic, we can see that sleep quality in general didn't change that much, but insomnia symptoms increased through the course of the days, and they increased more in women as compared to males. Depression and trauma also increased, and the level was similar for males and females. However, females started from a higher level of depression and trauma. And in terms of anxiety, instead, we can see that the males are the ones that changed the most. So they start lower as compared to females, but then they tend to increase their anxiety level through the course of the pandemic. And finally, when we go and look at the association between these factors and sleep, we see that in males, the association are fewer and mainly driven by depression. So depression seems to be the highest predictor of poor sleep quality and insomnia in males. No whatsoever relationship is found with empathy. And in females, instead, there's more relationships with depression, trauma, and anxiety being the highest predictors of both sleep quality and insomnia. But again, even here, no relationship with empathy. So we seem to find here that females and women seem to have worse quality of sleep, more insomnia, anxiety, and depression, and trauma during the isolation. These things seems to increase with the length of the isolation, especially in females. And the greatest predictor of sleep quality during the isolation period were depression, trauma, and anxiety, and no relationship was found with empathy. So these data are slightly different to what we found in non-pandemic time, where empathy was one of the greatest predictor of sleep quality. While here it looks like mood and trauma are more important, probably because there is a greater focus on the personal health and mental health rather than caring for others. In a way, we care for us first, and then we start worrying for others. And these are my acknowledgements. So I would like to thank my previous supervisor, Dr. Yaria, at the University of Calgary, and my current supervisor, Dr. Mark Poulen at the Cummings School of Medicine, my colleague Alberto, who's collaborating with me on this paper, and all the study participants that agreed to give me a bit of time to complete the survey. So here I would like to take some questions, and thank you for your attention.
Thank you so much, Veronica. That was great and very timely for sure. Yeah, does anyone have questions? Give it a sec. I know we're slightly over time. I just wanted to give a moment to if there was any questions at all. I don't know. Certainly lots more work to be done around COVID and sex and gender differences, not only in the physiological area, but psychological area for sure. So thanks for that work. It's really important, I think.
I have a quick question while I can. Yes, amazing presentation, and yes, very timely. I was wondering, I might have just missed it too, if your participants, when you're talking about depression, was it onset of depression during the pandemic or depression before the pandemic? And did you measure both of those things, and did they have different roles to play?
So this is a very good question. Actually, we used the Beck Depression Inventory. So this is a clinical scale, but actually it measures symptoms of depression. So I guess to have a clinical diagnosis of depression, you would need more than just one questionnaire, first of all. And then the other thing is that we do not have data before the pandemic. So basically, we just refer to normative data for a similar population, and saw that there was a heightened level of depression, especially in women, as compared to a similar population in non-pandemic time. But yeah, that's for sure is a limitation, because it would have been much better to have pre-post data.
Yeah, I think that would be great to know, and great even as a survey to say, have you been diagnosed before? Would be great addition to.
I mean, we have a question about psychiatric and neurological conditions. So many of the participants, yes, were diagnosed and also are taking medications. So maybe I could do a separate analysis between diagnosed participants and not. And I apologize with everyone because my daughter is not behaving. So she's been, Mia, shh, she's been talking and I am unmuted, so sorry.
No worries. Thank you so much.
Great. Okay, so we're just 5 minutes over. So thanks for everybody that's hanging on here. Great presentations today. Such, wide variety of topics, but also relevant to women's health. So thank you so much to all the presenters who took the time today and everyone who logged on to listen. Yeah, these are really fun presentations. We are going to be planning more in the future. I think we've got a few people interested already for September. So if you are interested, or if you know someone else is interested, we're also interested if you've got updates to your research. So if you've already presented, don't let that hold you back from asking if you got working on another project, or you've got updates to the project, results, or whatever like that. You can reach out to me or Travis, who is on, or Kate, where all our names are on the, I think, Women's Health Research Cluster website, or even through the cluster Twitter handle. Someone will get back to you. So if you know of anyone, just reach out, and we're going to try and keep these rolling, because I think they're a lot of fun and a good opportunity for us to practice our presentation skills and to share what we're working on. So I don't know if anyone else has anything to add. I think that's it for today.